We have a wee bit of housekeeping, so I'll start with that, and then we'll move into our presentation for the evening. So welcome everybody to the webinar called Emergencies, Disruptions, and Pitfalls in Telemental Health. This is the fifth of a 6-week series in the fundamentals of telemental health. My name is David Jefferson. I'm the Director of Training and Technical Assistance, and I'm your facilitator for this evening. And we're very excited to have Dr. Sarah Smucker-Barnwell. She's back again, and she's prepared another very interesting presentation for us. Throughout the evening, if you have any questions, please drop those in the chat box. We'll be pausing 3 times through the evening and answer some of your questions and see what else is out there that people want to know about. And we have certificates for everybody. And if you are signed up yourself tonight, you'll automatically get a certificate. However, if you are in a small group, what we'd ask you to do is please send us an email at thenorthwest@attcnetwork.org and let us know the name of the people that you're with tonight and their email address. That will assure that they get a certificate for tonight's attendance. We also like to survey all of our presentations. There will be a link to a very short survey at the end of the evening. We'd appreciate it if you would do that. You'll also get that link again in the follow-up email that will be coming out tomorrow. And that follow-up email will also include a link to the slide set so that you can review those at your convenience. And with that, I'm very excited that Dr. Barnwell is with us again. And what I'm going to do is turn it over to her, and here we go.
Thank you so much, David, and thank you to the NWATTC for having me. And thanks so much to everyone who has come. If it's your first time here, welcome. And if it's not your first time here, I appreciate your coming back. So today we're going to spend some time speaking about emergencies, disruption, and generally pitfalls in telemental health. So, this is, as David mentioned, the 5th of 6 learning series entries that we will be doing. And so at times tonight, I will make reference to material that we've covered in prior sessions. I try to find a balance between, briefly reviewing some of the themes we've spoken about previously, while also engaging new content, of course, which is why you're here. So, I will at times refer folks back to some of these prior courses, and as we have them on the slide, if anything looks of interest, please know they are available on demand at NWATTC's website. So I'm Sarah Smucker-Barnwell. I'm a clinical psychologist in the state of Washington, and I've had a career that has just had a great deal of fortune in terms of getting to do amazing work in telemental health. I am the previous founder of the VA's Puget Sound Healthcare System's telemental health team, where I had the great pleasure of serving veterans across 40 different locations in the VISN, or the what we would call the grouping of states in the Pacific Northwest. I was one of the authors of the American Psychological Association Telepsychology Guidelines, as well as some other guidelines published by American Telemedicine Association and other entities. And I have the pleasure of training at the VA Puget Sound Center for Excellence in Substance Abuse Training and Education. So being with you all tonight and speaking about the intersection of substance use disorders and telehealth is a tremendous thrill for me. And I am, I will jokingly say I'm an unapologetic telehealth evangelist. I really believe in this modality and its opportunity for us to bring the excellent care that you bring to clients to a diversity of populations. And, now more than ever in the context of the pandemic and during a time in our country where I think, a lot of people need support and outreach, and it's, an incredibly important period of time, that your ability to reach out and deliver good care is incredibly important and valuable. So thank you for being here, and thank you for your interest in this work. Tonight we're going to speak about the management of emergencies, And we're going to operationalize a little bit what we mean. So I'm speaking about concerns for safety for our client, concerns for that they may be unsafe for others. We're going to speak about technology failures, which may not fall under the true rubric of emergencies, but disrupt care nonetheless, and other pitfalls and barriers to care that enter into the milieu. The structure of our class will be largely organized around didactic lecture, where we will be going over these themes, vis-a-vis this PowerPoint slideshow. We're going to stop at various times for some live Q&A. So please, if you have a question, feel free to put it in the chat box, and we'll be sure to get to it as best we can in the Q&A sessions. Now, at times we may or may not have a chance to get to all the questions. And if that happens, please don't hesitate to submit your questions to nwattctelehealth@gmail.com. I oversee this email, so you'll reach me directly, and I'm happy to answer any concerns you might have. And if it's a question that I think others might share, I will enter it into the following week's session under a section I like to call That's a Good Question, which comes at the end of our evening. We will have some live video demonstrations, and then of course we'll conclude our evening with one more live Q&A. So anytime you give a presentation in technology, the technology will inevitably fail with almost a sentient quality shaming you. So I'd like to put this in my disclaimers. I do like to mention that I offer best practice recommendations based on my own clinical work, my understanding of the extant literature, and my experience and understanding of regulation as it stands today. I'm identifying best personal practices and guidance in a developing area rather than a standard of care. And this will never be a proxy for your state and jurisdictional regulations, your consultation with your own legal counsel or risk manager if you have access to those resources. And generally, I just like to mention, I'm not necessarily providing legal advice or clinical advice, I'm really just trying to give my best overview of this burgeoning area. In the spirit of disclosing all conflicts, I like to mention that in my professional life, I do provide telehealth training. So in as much as that is the case, I suppose I have a horse in the race of telehealth and, could benefit if it is democratized and disseminated everywhere. But this is because I'm a known telehealth evangelist. I really believe in this. If you ever had dinner at my home around the dining room table, this is the topic people don't want to bring up with me because it's the one I can't stop holding forth on. I really believe in the opportunity that this modality has for us to deliver good care and to improve public health. Okay, so our agenda today. We're going to start off talking about managing those clinical emergencies remotely. We're going to move on to speaking about technology failures and then some of the other pitfalls, inclusive of document transfer issues, issues collecting payment, and insurance and reimbursement. And as always, we're trying to find a balance. We will tap back to some of the themes we've covered previously in the series, but we'll try to keep that very brief. Our deep dives will be in new content. We're always threading the needle of ensuring that folks who are joining us for the first time gain the necessary information to utilize what they learned today, but also demonstrating our gratitude to folks who come back time and again, and ensure that it's not too much repetition. So again, I'll mention that any prior classes are on demand if you feel that a certain topic was given too short a shrift. So let's talk about some operational definitions. We'll move through these quickly. Telemental health, you'll see it abbreviated in my slides and elsewhere as TMH. This is the provision of any mental health service using any telecommunications technology. So this is inclusive of telephone and video conferencing and text and email and secure messaging. Many companies are moving in the direction of asynchronous communication. But transparently, I think that when many people say telemental health, they are using the term synonymously with video conferencing. And for the purposes of this evening, we're going to be focusing a great deal on video conferencing and telephone-based care. HIPAA, of course, that Health Information Portability and Accountability Act. This is our federal regulation that ensures the information that we speak with clients remains private and remains secure. And this, of course, includes our use of telemental health. So, this ensures that we are protecting that protected health information, or PHI, as well as the electronic protected health information. And as I always like to mention, I was really surprised when I started in the world of telemental health, what types of information may fall under that rubric. So individual IP addresses, biometric indicators, certain serial devices on our hardware, account numbers on our software, these things technically would fall into the realm of PHI because they could be used to identify someone as being a patient. So I thought it was very interesting and I always like to mention it. I had a question the other day that someone said, well, gosh, if I just stayed away from technology entirely, would I still have to comply with HIPAA? And it is true. HIPAA will follow us no matter where and how we give care. So the answer is always yes. Business Associates Agreement, you'll hear me refer to a BAA. This is a contract between a HIPAA-covered entity and a HIPAA business associate. So in this instance, we're the HIPAA-covered entity because we are professionals who must comply with HIPAA. And this document ensures that our technology partners, among other partners, are going to follow the same rules of HIPAA that we must and be good partners in maintaining that PHI and EPHI of our clients. Okay. So, when we're talking about emergencies for the context of today, we're talking about psychiatric emergencies inclusive of themes of self-harm and interpersonal violence. We're talking about medical emergencies that clients may experience. We're talking about instances in which we must report something emergently and in an appropriate time frame. And in lowercase emergency letters, we'll talk about some technology disruptions, things that require a fast response in order to ensure that we are maintaining care. A brief synopsis once more with feeling. Some of these themes that we've talked about in prior classes, I'm going to move very quickly here. And again, if there's more information that you need, please do go back to those earlier classes. So when talking about video conferencing appointments today, we're going to make some assumptions. We're going to assume that we are using a product designed for healthcare. Again, there have been some recent shifts in regulation, some executive orders, not actually regulation, they've been executive orders allowing us through Department of Health and Human Services and the Office of Civil Rights to use non-public facing video conferencing products. And these are your Skypes and your FaceTimes and your Zooms. These are not your Instagram Lives or your Facebook TVs. These are things that are just private between you and another client, but not projected to the public. So we're going to assume, however, for the context of tonight, that we are using a product designed for healthcare, because that will always be my recommendation, and that has given us a BAA. We're going to assume that we have pursued informed consent with our client and obtained their signature, either in person or digitally, according to what our jurisdictional rules may dictate. And as part of that informed consent process, we're going to assume that we have discussed an emergency plan with our client. We're going to really dig deep into that tonight. And we're assuming we are just documenting, putting this in our chart, putting this in our notes, keeping copies of the documentation that we receive from clients. We're assuming that we're going to assess appropriateness with our clients, and we're going to dig into this today. We're checking our jurisdictional rules, and I will again mention the ASPPB, the Association of State and Provincial Psychology Boards, does a very nice job going over some of the executive orders state by state that have occurred that give us temporary licensure permissions across jurisdictional boundaries. But generally speaking, we always want to check with wherever we are practicing what the rules are and how they're changing in the context of COVID, because they are changing and changing quickly. And we're going to assume that we have prepared our office to be appropriate for a telehealth appointment, which was the theme of about 2 classes ago. We're assuming that we've decided what services we're providing, what population we're serving, and we've thought a little bit about how we're going to transfer documents with our clients, how we're going to communicate with them between sessions, be it old school, using the telephone, or perhaps using a more high-tech solution, such as a secure messaging product, or perhaps something integrated into our electronic medical record. And we are going to assume that we have already determined how we are going to collect payment from our clients. Okay, so let's get down to some of the new material here. So I'm assuming I'm preaching to the choir somewhat when I talk about the critical importance of emergency management in behavioral health. Completed suicide, I believe, is the 10th leading cause of death in the United States. About 50% of those do involve firearms, and I believe this varies pretty significantly as a function of gender. And what I found really fascinating as I was reviewing some research was the statistic that 90% of individuals with a completed suicide would present to healthcare within weeks of months. And this was often in a primary care context, not necessarily behavioral health context, but they were telling someone. And I thought that was a fascinating and tragic statistic. This is a broad and diverse literature, and I would not purport to be, a leading expert in this area by any means. But I think, it is well known to all of you that this is an important area and something we need to be very thoughtful of as we translate this into telemental health. Many of us have had the experience of violence risks reported in therapy. Perhaps we have learned as mandated reporters of reports of prior abuse that have occurred, be it to, in general, in our clients' lives, or perhaps they have been the perpetrator of abuse, things that have occurred in their past, as well as things that have occurred to others contemporaneously. And this is where being aware of our own jurisdictional reporting rules is going to become very salient, because certainly this varies greatly, and this is one of the significant challenges in emergency management and telemental health. My jurisdictional rules in Washington differ significantly from other jurisdictions within these United States. And understanding these conflicts, particularly if we are going to, in very specific and permitted circumstances, serve clients over jurisdictional boundaries, most often over state lines. So let's think a little bit about clinical assessment, thinking about what is going on with the client, environmental assessment, where that client is, where they are located, and the resources available to them. And then care assessment, what level of care is most appropriate in the context of the information we have just learned. So let's break this down a little bit more. I really encourage folks to think about standardized screening measures for things such as self-harm and violence risk assessments. I'm going to offer some resources later in the presentation, but this is, as I've mentioned, when speaking about intakes and just generally clinical engagement, I think there is this opportunity to return to some of those more structured measures that perhaps as we get along in our practices, we lean less on them than perhaps earlier in our practices. But I think they're wonderful tools, and having sort of like structured clinical interviews, diagnostic questions helps us guide us to make sure that we are asking all the things we need to ask to get a clear picture. So, I think for me, this is an ongoing process. I try to do a thorough intake in which I'm well understanding my clients' prior emergencies, inclusive of themes like behaviors of self-harm, harm against another person, hospitalizations that have occurred. I try to, as part of my informed consent process, indicate that this is something we're going to check in on regularly. I want to inquire about my client's safety and the safety of others. So I let folks know, and I benchmark the expectation we're going to be talking about this. And then, of course, symptom assessment and symptom monitoring are going to be a big part of how we assess our clients' safety in real time. So I think telemental health as a milieu, if we know that these are some of the components of good emergency management and good assessment, telemental health as a milieu has some specific and unique challenges. Of course, we know there are inherent challenges to assessment when meeting remotely with a client. Even assuming video conferencing, where we would see the client, we have an impoverished view of observational data. We are less able to see our clients' physicality, to see how they move, to see, that tapping toe or that, picking cuticle are things we're going to miss. We miss the small moments outside the treatment room. Sometimes I've had it happen where someone's in my waiting room having a very heated phone call when I come out to get them. And I really have a clear indicator that something's going on. In a telemental health session, I'm not going to have these small moments that occur in transport. We have, we can be less certain of how and why people are responding. So the example I like to give is if a client is looking away, staring down, sighing deeply in my office, I may make one set of assumptions about that. I mean, they might be right or wrong. If, however, someone is doing it in a telemental health appointment, I may have that set of assumptions, but I may also wonder, are they looking at their phone? Are they responding to something going on in the home, excuse me? Is there someone else who's joined the room and now impairing privacy or confidentiality? I think we just are at an inherent loss when we are doing assessment remotely. And that's not to say it's not still good to do, but I think there are ways in which we have to be really thoughtful and ask more questions. Of course, when we're meeting remotely with someone, there is an inherent some limitation to be as responsive in real time. If someone's sitting in my office and having an emergency, I dial 911, and emergency services come to that client. I think now it's certainly 911 is pretty darn good at getting the right people to the right place, but there's a little bit extra step there. Now I'm contacting emergency services who will then need to triage that call to a dispatch that's regional to the client. So when you actually make this call, they're going to typically connect you with someone who they're going to stay on the line with you, but they're going to connect you to dispatch that's going to be close to the client. And so there's a little bit of delay and a little bit of diminished opportunity to respond immediately. And of course, my ability to intervene in any sort of physical manner is very much diminished. So I've had it happen when I worked in a hospital-based setting that I had a client have a fall. And this was something that, I contacted emergency services right away, but I was able to be there with them physically, move things out of their way to make sure they weren't harmed, and then to assist when the appropriate medical folks arrived. I could be a part of that solution for that client. Of course, when I'm meeting remotely with someone, I cannot. As we talked about last time, I think there are some inherent challenges to clinical alliance and rapport in the modality. I really believe this can be overcome, and I believe that it is worthy of investing in. But I want to acknowledge that when we are asking clients to disclose, emergent concerns, these are very sensitive themes and sensitive topics. And we know that improved rapport and improved therapeutic alliance will only aid us in, getting to the truth of what's going on with our client. And so I think when we're thinking about some of the impediments to sound emergency management in the context of telemental health, thinking about that clinical engagement piece and rapport feels very salient. And of course, the communication quality. If my call is delayed, or if the audio is hanging or very out of sync with the video, if the call drops and is interrupted, these types of experiences, I think, reduce the probability that someone is going to be as forthcoming. And I have to say this is, I've only read a few studies on this, so I don't want to overstate this, but the studies I have read talk about the negative impact that technology disruption bears on therapeutic alliance and rapport. And I think if we think about this in the context of the disclosure of sensitive information, this is going to be a challenge to this as well. Of course, we are not in a position to control the environment of our client, so I think when someone is in my office, well, that's my environment. If someone else barged into my office and were, disruptive or causing some sort of emergent circumstance, I would be in charge, so to speak. I would be the one contacting emergency services. I would be, boots on the ground to help. If this occurs in my client's environment, of course, this isn't something that I control. So again, it's just an additional factor as we're thinking about the unique challenges of emergency management and telemental health. Being aware of what resources are available local to where our client is located. So, if I contact someone for a wellness check, for my client in Pierce County, Washington, I know that the mental health professionals, or MHPs, will be going to my client's home and helping them. If, however, and I believe this is correct, so if anyone's from Snohomish County, please correct me. If, however, someone from Snohomish County is having a telemental health appointment and I need to do a wellness check, it will be the police going to their home. Now, they have training as well, but I want to acknowledge that it's a different resource and it's a very different dynamic. Additionally, in some places I have served, there has been an obvious and great resource, if my client needed to be assessed for potential inpatient care, I felt really confident. I knew there was a hospital right there and that they were well-staffed with psychiatrists, psychologists, social workers, and other counselors. Alternatively, I've served folks in very rural communities where there really was no hospital. It was a plane ride to get to a hospital, and that we were going to be in a much different circumstance if they required inpatient hospitalization. So, being cognizant of what is by the client. I think this is, again, a unique challenge and an investment in provider time when we're thinking about managing mental health emergencies or physical emergencies remotely. And of course, treatment planning. I like the little medication bottle icon it gave us. Treatment planning in thinking about, well, okay, so if my client needs an additional augment for care, if I think they do need inpatient hospitalization, if I think they need an addition of a DBT skills group, if I think they needed something more than individual therapy with me, is that available in their community? So let's talk about managing these emergencies remotely. Here are our challenges, and let's start articulating through some of the options we might have as we think about doing this, thinking in advance and planfully setting ourselves up to succeed. So I wanted to offer a few publications on telemental health and emergencies. And, I don't necessarily expect everyone to run out and read these, and forgive me, the 2007's a little bit older, but I think all of them offer nice data on the fact that emergencies can be handled safely in the home and in as well as supervised clinical environments, and offers us some guidance and some research. So I'd like to mention this, and if folks are looking for publications and citations, please, I wanted to include these. Okay, so generally speaking, there is research on between session safety management. So, we know that from session to session, it's actually the standard of care to use telehealth. When my clients in my in-person office are having a concern between sessions, they're not going to show up in my office and, hope I'm sleeping there. They're going to call me on the telephone. They're going to reach out through the portal. And this has been a standard of care for many years. In addition, we would often send clients to toll-free numbers or to emergency telehealth options between sessions. So, we know that telemental health is available to help us manage emergencies safely in between sessions. There is good research on the validity of using video conferencing to manage self-harm and suicidal ideation in home as well as in clinic. And that would be that, I believe, Luxton article from 2012 that I mentioned in the prior slide. And I'd like to, again, I always encourage folks to remember that for many years before we called it telehealth, we were sending folks to hotlines. We still do. I think as we think about, again, this is our advanced planning, and I really always encourage us to think about where we are in terms of our willingness and our desire to manage remote emergencies. Of course, we never, ever want our clients to have an emergency. We want them to be well, and to be healthy and happy. And, I think we need to pause and consider our own scope of practice and, how comfortable do we feel assessing these circumstances, acknowledging we're never going to know with perfect clarity. We're never going to know for certain who will have an emergent circumstance and who will not. But I think that there is this opportunity for us to think about our own training, the populations we work with, and where emergency management falls into our practice. And I think that this is a general sort of theme that we're going to be talking about. So as we think about our own desire to work with populations who are struggling with their clinical stability, if they're struggling with histories of violence, I think what I really want to communicate is that there is permission for folks to determine what services they offer and to decide what is within their scope of practice and what isn't. We're always assessing in telemental health, and on those first contacts and on an ongoing basis, whether or not a client is appropriate for telehealth. And that could be things like, do they have barriers to care? Do they have access that's in person and available and appropriate? What is their diagnosis? I will share that I'm always a little more reluctant to deliver telehealth care to anyone for whom there is a diagnosis that involves avoidance. So if agoraphobia is among their diagnoses, if social phobia is among their diagnoses, pre-coronavirus, that would be someone I would have absolutely brought in person. Now I'm offering telehealth to all my clients, and so I think it's a little bit of a different circumstance. But again, as we are thinking about assessment for telehealth appropriateness, I think there's this opportunity for us to be thoughtful about what diagnoses make the best fit for us. Of course, the client's interest in the modality has always been a contributing factor. This is the first time in my professional career where you would even contemplate delivering telehealth services to a client who might not prefer it. For some providers, either their own choice or the organization that they work with, they are delivering exclusively telehealth, and clients, had the option of either not receiving care with them or receiving it via telehealth. And this is a very novel circumstance. So I think it sort of upended a lot of our thoughts about appropriateness, because previously, of course, we would have seen these clients in person. But I also think we need to be thoughtful about the client's clinical stability and their history of emergent circumstance. I've had clients for whom they have a strong history of, recurrent hospitalization, concerns about self-harm, concerns about interpersonal violence, and I think as a clinician, I will have to make the determination of my willingness and comfort to manage that remotely or in person. I mean, many of us determine what level of symptom severity and clinical stability we are willing to work with in our in-person practice as well. So telehealth is no different. I think we need to pause and be thoughtful about our own comfort and willingness to engage and deliver services remotely. So I like to think about the client's prior treatment history. If they have, some folks, I'm the first telehealth therapist they have seen. Some folks, I'm the 7th or 8th telehealth therapist they've seen. And that's definitely going to be something I'm contemplating as I consider whether or not to bring them on as a new client. I want to be thoughtful about their reaction to the modality. I've had a few folks tell me that, boy, they're just really not sure this is for them, and I think I'll have to be thoughtful about, how willing am I to do that good work and really work hard to make the rapport work. But additionally, I've had folks say that meeting thusly has triggered ideas of reference or delusions or concerns that have actually diminished their clinical stability. So when indeed the modality itself could contribute to emergent circumstances, I think we need to be really thoughtful about it, and something I ask very explicitly about in my intake process. And of course, always doing a thorough assessment of risk factors for self-harm and risk factors for interpersonal violence. And again, I would point towards some of the standardized measures that walk us through that, because I think, putting it on my memory to remember every single one of those risk factors is a poor bet. We want to be thoughtful about the appropriateness of our client's environment. And of course, we're always speaking about the availability of a private space, the availability of technology, of internet service. We're speaking about these more sort of mundane factors. And if we go back a few classes, we do a really deep dive on those. And those remain very important. But I think today what we're also really speaking about is the safety of the space. I think the first clients that I'm transitioning back to in-person care are those for whom domestic violence is in their life. I am concerned about the safety of their home environment and the appropriateness of that home environment. We've had to work very hard and be very thoughtful about boundarying it in a way that felt like it was appropriate and safe for them. I want to be thoughtful about their exposure to violence in their home, who else is in the home, and whether or not we can deliver care safely to this client, again, without making it more likely that they have an emergent circumstance in their life. So always we're discussing benefits and risks of the modality as part of the informed consent process. And, generically, again, this includes things like anytime we put information on the internet, there's risk. We like folks to well understand that, if they're speaking loudly in their home office, there's a potential for them to be overheard, themes like this. But I think we also need to inform them that there's the potential for diminished emergency response. If they fall over in my in-person office, and require basic life-saving CPR, I'm trained in that. I could help them. Remotely, I cannot. I can contact emergency services. I can contact a support person they have identified to assist in case of emergency, but I can't actually help. And then, of course, being really cognizant of what our jurisdictional reporting rules are and making sure that we're very transparent with that, with those rules with our clients. So as part of my informed consent process, I like to be very, very straightforward with clients, letting them know what type of circumstances I have an ethical obligation to report to authorities, making sure they're aware of what triggers those reports, and having a conversation, well in advance of them sharing any sensitive clinical information in the context of that intake. So I'd like to actually dig in with my clients in that informed consent process regarding the specifics of my reaction, if they were to disclose concerns about harm to themselves or harm to others. And I really do let folks know that even though we're meeting remotely, the rules are very much the same. I am going to pause, and this is going to become our focus. If I want them to feel comfortable expressing this to me, and I'm certainly never seeking to dissuade it, I also want to let them know that I will take it seriously, and that we will talk about it. It may be something that if they have a history of this in their life, I will explicitly ask them about. And I'm really just trying to introduce some of my ongoing assessment practices so it doesn't feel out of left field. So as we, continue on, just as we talk about those mandated reporting circumstances, so nothing feels out of left field should a circumstance come up, so too, I want to benchmark expectations regarding how I might respond to suicidal ideation or violent ideation, letting them know I will take this seriously, we will engage in further assessment, I will follow up, and to really, again, not to feel punitive in the moment, but just to say, this is what I conceptualize good care to look like, whether we're over a distance, meeting remotely, or whether you are in my office. All of this culminates in my mind's eye in the creation of the emergency plan as part of the informed consent process. So again, we're documenting this plan in advance of initiating care, in advance of beginning care. I like to have it embedded in the informed consent document. I have people complete it before they ever come in and start that intake with me. It's something I will explicitly discuss with my client. And again, I'm seeking to benchmark my expectations about what's going to happen. And I like to give my client the opportunity to ask any questions and make sure that they feel satisfied as they're understanding what's going to, how this will be involved in their care. This is tiny. I'm quite sure you cannot read it that well unless you have excellent vision, better than mine. But all of these slides will be available to you online, and it should be available to you in a PDF format. So I wanted folks to have this template. This is something I want to be clear. This is a product that I created. It's not endorsed by NWATTC or any other entity per se, but it's just a basic template that I feel goes over the type of information we want to have: the client's name, their address, a telephone number where we may reach them, an alternate telephone number, identifying a support person who might be available to help in case of emergent circumstances, their name, as well as their telephone number, and then some initials that allow us to contact them. I will say I actually do a separate release of information for the support person. I like to sort of duplicate that documentation. And then I review some of the usual things that would happen. I let them know that in case of behavioral or medical emergency, I'm going to contact local emergency services. This could be the paramedics, the mental health professionals, or local police. They're going to come to your house, make sure you're okay. And if it's appropriate, I'm also going to contact your support person. And I usually put a little blurb in there that just indicates this is different from technical emergencies. This is a separate thing. But if that happens, I'm going to call you. Then I ask my client to sign it. And I include this in the documentation for that client. I think this is really, to me, very important that we walk through what this would look like. And I have to say, this is something anecdotally that many clients would like to give short shrift. I think a lot of my clients would like to skip the informed consent process. Generally, they're very polite and lovely people, but if I was a betting woman, they might think I'm belaboring these points, and I also gently note that, well, this may not be a concern right now, and it may not ever be a concern. I hope not, but I would much rather, discuss these now and really give you the information so that you feel well informed of how I would seek to take care of you. And if you have any concerns, let's talk about it now and not, in the throes of an emergency. So this idea of a support person was something that was very popular in the early aughts. I would say it was like a very popular notion for telehealth. It really fell out of favor a few years back, but what's been very interesting to me, sort of in our post-COVID-19 world, I see the reemergence of the support person really, coming back into favor. Actually, that 2012 article by David Luxton and his colleagues, as well, I believe, as the 2007 article, talk about this important role of a support person. So I think it's been there in academic telehealth all along. I know it has come in and out of favor clinically by folks. I think especially as the modality becomes democratized and more people are using it, it's additional work. You have to ask your client to think of someone in their life, and are they comfortable disclosing that they are in therapy? Are they available? Are they accessible? It's great if your friend who lives 3 states away knows you're in therapy, but if they can't come and open the door for the paramedics, they don't have this high potential to help. So, when they're able to identify someone, we're always balancing, someone who is appropriate, who would be supportive, for whom we could obtain that release of information, but then additionally, someone who is functionally well positioned to help in case of emergent circumstances. I think there are pros and cons to this, and I want to acknowledge, to be very clear, I would never contact a support person if my client was if they said they were getting a firearm. I would never contact that support person if they were endorsing violent ideation. So I feel like there is a little bit more liability and risk in this, when we're bringing another person into it. So that to me falls in the cons. I think there is just a practical opportunity for this person to be very helpful, facilitating a person getting the care they need. So I think it's a personal choice. I don't have a support person for every single client I see, but if there is an heir apparent, if there is someone who quite obviously to me would be a good match for this role, I really do try to go out of my way to get that ROI, document it in the chart, and benchmark the expectation that should we need to, I would contact this person in order to obtain, the help they needed. I want to just take a pause and speak specifically about firearms. I think there's in the Carolyn Turvey article, that was the second of the 3 citations that I offer. They do a nice job of talking specifically about firearms and in telemental health, asking folks to use trigger locks if they do have a firearm in the home. And of course, we know trigger locks generally offer additional protection in suicide prevention. But I think we know that access to firearms increase lethality of risks of self-harm or risks of interpersonal violence. So, I would guide people to those American Telemedicine Association practice guidelines for video conferencing based TMH. That was that second citation on the list. And, you think a little bit about how you wish to address this. I have some colleagues actually who decline offering telehealth services to folks who have firearms in the home. I don't personally do that, but I think I'll mention it. I think it's interesting. I do always strongly encourage folks, if they have any concerns, ideation about harm to self or harm to others, my first recommendation is that we take the firearms out of the home and give it to a trusted adult, who could watch them for them, surrender it to a police station if that's not an option, or at very minimum, use a trigger lock. So again, I would not purport to be the ultimate expert in all themes of suicide prevention and emergency management, but in the context of telehealth, I think that these things are even more salient. And the reason I really think this is that telehealth is this modality under observation. In some ways, I do believe telehealth is somewhat in the fishbowl. So the more we can, use these best practices, and the more we can prioritize the safety of our clients, I think we not only improve our clients' outcomes and well-being, but I think it's a good case for risk management in our own practices as well. And of course, our next session, next week, we're going to talk a lot about risk management and all those little dotting of the I's and crossing of the T's we can do to do ethical telehealth that also manages our own exposure to risks. I mean, perhaps this goes without saying, but telemedicine increases clinician safety as well. I have consulted with hospital systems who sought to implement telemedicine for clinicians in particularly high-risk circumstances. And in one circumstance, I found this a little controversial. What they were trying to do, and we ended up doing something a bit different, is they were changing their formulary, in which they were removing opiates from the formulary for many, many clients. And this was a big deal. There were people who had used opiates for pain management for decades, and we could argue whether or not they were appropriately prescribed or whether that was the best thing for the client. I don't know, and I would be outside my scope to opine. But needless to say, these folks had been using them for many years, and to receive the information that they would no longer be able to have them to manage their pain is a pretty big deal. And what they wanted to do was a project in which we would have all of this news delivered by telemedicine. And I had a lot of compassion for why they would want to do that, from the perspective of people were going to be very upset. And this was an environment that had a lot of volatility. There had been violence against clinicians, particularly around this subject. The clinicians were scared. And I understand why they wanted to use telemedicine to do that. I did worry that the modality itself could exacerbate, being given really bad news over video conferencing, I think lacks a certain something, but I also appreciate why they were considering it. In the end, we came up with another solution, but I think that we need to balance making sure that we are prioritizing clinician safety, while also carefully considering the impacts on rapport. Another example that I think is very salient is early in my career, I do a fair bit of anxiety spectrum work, and we would do home visits for clients who perhaps had demonstrated hoarding behaviors and needed to do some practice with discarding in the home. And there were some safety concerns with that. Sometimes their homes had some significant impediments to good health and easy breathing. And I think over time, we made decisions as a clinic as to whether or not we were going to not continue that practice for clinician safety. I think this is a nice example of how we can do work that really helps our clients, that's present with our clients, that can build rapport, while also managing our own health and safety. And of course, now more than ever, in the context of coronavirus, many of us came to this decision to offer telehealth in the context of public health and our own health and safety. And so I think now more than ever, thinking of this as a tool to keep us well in order to continue to serve our clients and continue to help others be well is very salient. Okay, today we will have vignettes based on doctors, red, pink, and blue. So Dr. Red. Dr. Red has a practice focused on life transition, anxiety, and stress. He has some training in suicide assessment and response. And, there are some factors in his quarantine that have resulted in him working from home. So he has decided he's going to be seeing clients from his home. He has his kids at home. He's having to change his schedule somewhat and abbreviate his sessions somewhat in order to make all of this work. So he has a client that he wishes to see who has a significant history of self-harm with recurrent hospitalizations, and he's contemplating whether or not he thinks this is a good match. This is something he's not as comfortable with clinically as some other themes, so this would be on the newer side for him. So for this provider, I would want to be thoughtful about, well, what is his experience in telemental health? Is telemental health another new thing that he is adding, to his clinical practice, or is he old hat at it? If he's working from his home office and he's homeschooling kids and he's, juggling a lot of things, what is his bandwidth right now to help manage a clinical emergency? Is he available? Does he feel in a place that he can do this work? I want to acknowledge many of us are thrust into this role in moments where we may not feel that we have the bandwidth, and we do our best for our clients. That is our priority. And sometimes if we can foresee a circumstance, we have the opportunity to ask ourselves, can I deliver the best quality care that this client needs? Am I the right person at the right time? And what is Dr. Red's willingness, to make himself available in these ways, to perhaps obtain additional training, and to, make sure that he is delivering the appropriate level of care for this client who has had recurrent emergent circumstances. We want to be a little bit thoughtful about some of the legal and ethical issues when managing an emergency remotely. So again, we're going to think about what our jurisdiction requires of us and the guidance they give us. I want to acknowledge that civil commitment guidelines vary significantly among jurisdictions, as do themes of confidentiality and duty to warn. An example I can think of is a case in which a provider located in Washington state was delivering care to a client residing in Texas. And this was someone who understood the jurisdictional concerns and knew that they could not practice without a license in both jurisdictions. Their solution, in fact, was to be licensed in both places. They actually spent half their year one place, half the year the other place, and they maintained clients in both places year round. However, they had not really thought through the concerns regarding the duty to warn discrepancies in these two jurisdictions. In the state of Washington, we have Tarasoff regulations that require us to disclose a threat that a client makes against another person. We must disclose that to make sure the authorities warn this person and protect the person who could come to harm. In Texas, at that time, there was no such duty to warn. And indeed, we could find other jurisdictions still where the duty remains with confidentiality. There's actually a duty to maintain the confidence. And I believe in Texas, there's an optional piece. You could warn, but there is no duty to warn. Now they have a circumstance that they're sitting in Washington, the client's sitting in Texas, and the client discloses that they intend to harm someone. And they're at a loss. They're not quite sure what to do. And this is a great circumstance of where, thinking ahead and thinking through those legal and jurisdictional concerns, they could have had a conversation with the client right from the jump street in that informed consent process in which they discussed, if this type of circumstance comes up, here's how I'm going to handle it. We're going to follow the rules of Washington, and I'm going to make that disclosure. I will say, acknowledging there's no one size fits all answer to such questions. My general rule of thumb is I tend to, in my discussion of interjurisdictional conflicts, when I'm appropriately licensed to do so, I will err on the side of public safety. So I tend to err on the side of duty to warn. I know other people make other decisions, but that's what my informed consent document says, and that's the conversation, albeit an uncomfortable one, I am having with clients, well in advance as part of that informed consent process. I'm thinking about who manages psychiatric emergencies. Is it the MHPs, those mental health professionals? Is it the police? Is it someone else? Who does a wellness check if I call, and they need a wellness check? If I call 911 and I'm connected to their local areas, who shows up at that person's house? Is it the fire department? Is it someone else? And I want to be transparent. Something in my mind is, where is my client's safety in all of this? If they're having an emergency and they need help, I need to get help to their home. And that's the full story. And I will be totally transparent with you. When I've had clients who are having psychotic spectrum symptoms and I have concern that they are at a risk to themselves and self-harm, I have worry in my heart, about just contacting emergency services and sending someone over that I don't know their level of training, that I don't know, if they are going to appropriately de-escalate the situation to their home. Now, of course, I'm going to fulfill my mandate and do my best to get them the correct services. But this is, again, we're having that support person. If I have someone additionally who I can contact to help facilitate the interaction and, keep everybody safe, I think there's real value to that. Thinking about, again, if at some point I determine that additional care is needed, that what my client needs is outside the scope of just my practice, being thoughtful about what is available local to my client. Am I augmenting care with an additional telehealth resource? And if so, where would I refer to receive such a resource? Is there something local to my client? Is there a hospital? Is there a mental health clinic? Is there a primary care clinic, with resources? I think in our more urban areas, this is less of an issue. So if I'm delivering telehealth client to another person in Seattle, gosh, I know a lot of the resources here, and they are many. There's a great embarrassment of riches of mental health providers here in Seattle. If, however, I were to drive a few hours east, that's less the case. Or when I've served clients in rural Alaska, the nearest hospital, is quite a trek away. And so being thoughtful about what are my options for referral in case of additional care necessity. Because I think always we are trying to be thoughtful about what would we do if there was no good referral? Because we're thinking about the theme of ethical abandonment. We want to make sure that we are not just leaving a client high and dry. And this is where I think investing in advance of thinking, what would I do in these circumstances is very, very valuable. And I wish I could tell you there's always a good answer. Sometimes there's not a great answer. But if that's the case, I want to talk about I want to talk about that with my client beforehand. I don't want to wait until we're in an emergency circumstance. So for my clients that lived in very rural Alaska, we discussed the fact, if you needed inpatient care, or if you needed hospitalization or a medical emergency arose, probably what we'd have to do would be to contact this entity, which is pretty far away. Can we talk about that? What else do you do when you're in emergent circumstances? So not to say that I wouldn't be contacting the emergency services, I absolutely would, but I might be augmenting them. Turns out there's actually a visiting doctor who lives, only 30 minutes away, and he sometimes helps, or turns out the primary care clinic actually has pretty good risk assessment services because they're the only game in town. So being aware of what is going on in that community, I think, is a worthy investment. And this is where sometimes folks will tell me, gosh, I'm really excited to open my telehealth practice, and I know I can practice anywhere in my jurisdiction, so I'm just going to do outreach to the whole state that I'm licensed in. And there's something so lovely and entrepreneurial about that. And I appreciate why they'd want to do that. And at the risk of being a sad gray rain cloud, I usually counsel them against it and suggest initially, anyway, having a more focused outreach. Find a community, that is in your jurisdiction that would benefit from additional behavioral health care. Learn about that community. Where do the referrals come from? Where can you refer to? Make yourself knowledgeable, and make yourself known to the other providers there. And in doing so, I think we better position ourselves to handle crisis and to deliver the best care remotely that we can. So let's talk about Dr. Blue. Dr. Blue treats clients with dual diagnosis. She wants to serve a client who has traveled across state borders. So this is someone who began in her state, but then because of quarantine concerns had traveled to another state and was quarantining there. This client has a history of violent ideation, and Dr. Blue is a bit concerned that the current stressful circumstances is not helpful to what's going on. So Dr. Blue would want to be thoughtful, review that ASPPB website to learn more about current state temporary practice guidelines. May be the case that there is some permitted path for her to serve the client across jurisdictional lines temporarily. She would observe when any executive orders that had occurred expire, because some of them are starting to expire. So she'd need to be thoughtful about that. She would examine if there are any differences in reporting requirements between her home jurisdiction and the one where the client was going. And she would discuss this with the client. She would, let them know, hey, this is how I'm going to handle a situation like that. What do you think of that? And Dr. Blue would want to use more formal assessment measures, particularly as they're engaging in telehealth, making sure that she is staying on top of this concern and documenting that she has done this assessment. So let's speak briefly about administrative issues. So thinking a little bit about what is your tipping point? What is your algorithm? And again, this is where I would strongly encourage us to use evidence-based assessment measures. So, I think I actually really like the SAMHSA resources they do on their, and David, if you wouldn't mind putting the samhsa.gov website, they have a great number of wonderful assessment tools geared towards assessment of violence risk, assessment of self-harm risk, all within the context of substance use disorders, SUD, which I really appreciate and I really encourage folks to take a look at. Okay, so when we're planning that we're not planning for an emergency, when we're creating a plan for our response to emergencies, we want to have clear roles and responsibilities. We want to have a protocol for, when we're going to enact our plan and how we're going to enact, whether it is in session, one set of protocols there, or whether it is between sessions. And again, letting our clients know, if you disclose to me ideation regarding self-harm in the session, the first thing we're going to do is some additional assessment. I'm going to ask you more questions, and there's one of several potential outcomes. We may decide that there is not an imminent risk, in which case we're going to be establishing monitoring protocols and talking about potentially meeting more frequently. If, however, we decide there is imminent risk, we may be discussing whether a higher level of care is indicated at that time. And this may differ from how we're handling it between hours. Some folks are going to be using telephone or video conferencing to reach out between sessions and have some sort of additional assessment. Others may be scheduling the client to have an in-person assessment if your jurisdiction permits that and it is safe and healthy for you and the client. So, I think for some of us, this would trigger a return to in-person care because we've decided we don't want to be managing emergent circumstances in our telehealth practice, and for others not. So here again, I think it's if we've invested in advance thoughtfulness regarding when and where we feel comfortable managing emergencies in telehealth versus in-person care, acknowledging in the context of COVID-19, it may be all telehealth for us right now. But again, having thought it through in advance, I think results in a more smooth process if and when, heaven forbid, it does happen and you're managing this emergency remotely. Okay, so we're informing the client of what's going to happen, who's going to be involved, and we're pretty transparent on the decision tree. So what I mean by that is I'm very transparent with my clients and I say, if I feel, that there is Ideation about self-harm, if I feel, I probably wouldn't use that language, but if I let them know if they have ideation with what I perceive to be active intent and plan, that's the point at which I'm going to want additional assessment, and we're going to be considering whether or not additional care is indicated. So too, if they were to disclose violent ideation towards another person, then I would lean into one of those formal assessment measures. And if I did feel there was a viable threat, I have a mandated duty to report it. If they did disclose abuse of that they had suffered, that someone they knew of had suffered who was in a protected class, or that they were themselves perpetrating abuse against someone in a protected class, those people under 18 and over 65 in the state of Washington, then so too, this is where I might be triggered to make a mandated report. So I try to be as transparent as possible, again, having no surprises. So what are some of the general clinical issues that might emerge? So here again, I think maintaining that clinical engagement in emergent circumstances remotely, it was hard under the best of circumstances, and there's additional challenge here. And here again, we have impoverished observational data. If someone's disclosing, distress, if someone's disclosing anger, if someone's disclosing something really difficult, we are at diminished capacity to see some of those indicia that we see in person. And acknowledge that, the awareness of strong affective states, may impact how they are behaving. It may be harder to interpret. I think I was reading one study that was talking about how, significant distress among clients read as very flat on, telehealth calls, and that it made it more difficult for the providers to discern what was going on. So here again, slowing it down, asking questions. And I think, we acknowledge that there are times at which when we, make a wellness check, or we make a report to CPS, or, we contact the paramedics, there's the potential that this is going to significantly impact our clinical relationship. We're reporting difficult information, and at times this is going to have severe and negative consequences on our clients' lives. So again, being aware of the local process, being aware of what will happen, sharing that as much as we can in advance with the client, so that we are not serving up surprises under emergent circumstances. I will put in a plug that I like to begin each session verifying where the client is. I think it's a good thing to do generally, but particularly when we're thinking about managing emergencies, you don't want to be finding out right in the middle of an emergency that, oh, actually I'm at my cousin's house this week. So beginning each session, verifying that they are at their home, verifying, or wherever that you meet with them, and understanding where that location is, verifying their telephone number, where they may be reached, and making sure nothing about their contact information has changed, or the contact information for their support person. We want to know who is in the home. I always like to ask, is there no one in the house and it's just not even an issue for privacy and confidentiality, or are there 10 people in the house? What their local resources are, and understanding, their wider community. Where do they live, and what is available to them? Thinking about your prior training in risk management and response, your willingness to engage themes of emergency management when also doing telemental health, and thinking through the risks and benefits of this. I think there's tremendous opportunities to deliver really excellent care, tremendous benefits to make sure that clients get the care they need. And, there is risk. There's risk to your practice. And I want to acknowledge that there is, this is a modality that is under significant observation. I do believe it is somewhat in the fishbowl. So I think people tend to cross their T's and dot their I's even a little bit more conscientiously in the telehealth modality, because it is newer, and because I do think at times folks have had board complaints and they can run into attitudes of technophobia. And I don't say this to be spooky, or make anyone think this is a bad idea, but I do say it because I think it's a reality. And so as we need to be very thoughtful about what the risks are to our clients, and of course, to our practices as well. Considering those formal measures and trainings for suicide risk assessment, violence risk assessment, and exposure to violence and family violence. Assessing for safety for the client and for others. Having transparency about when and how you make reports, and contemplating contacting that support person. We want to contact the appropriate resources for the client, We want to remain on the line while those resources come to the client. And then, of course, we want to follow up. So if indeed we do need to engage emergency services, we want to get the right people coming to the clients. We're going to stay with them, while those people come. And then, of course, we follow up appropriately to continue our own care, or if necessary, to help transition care to a higher level of care. Hi, Mr. Barnwell.
Hello, Dr. Smucker.
How are you today?
I'm not feeling great.
Oh, what's going on?
Carrying a lot of tension. I haven't felt well all morning.
Okay. So it sounded like this began this morning. Can you tell me a little bit more about it?
Energy's weird. Having a hard time just kind of getting around. My chest feels kind of tight. It reminds me a little bit of how I felt before I had a heart attack a few years ago.
Okay. Mr. Barnwell, are you at your home at 123 Skinner Street?
Yes, I am.
Okay. And who else is in the home with you right now?
Right now, the dog.
Okay. Mr. Barnwell, in light of your health history, and I know we talked about this during our earlier emergency planning, I'm thinking we should have you checked out by medical professionals. What do you think?
That's a good idea.
Okay. I'm going to ask you to hold on for one moment, and I'm going to contact the emergency services to come to your home and help you. Just stay on the line.
Okay.
Okay, Mr. Barnwell, I have contacted emergency medical services. They will be coming to your home. I'm going to stay on the line with you. Mr. Barnwell, where is your wife currently?
I think she's out shopping. I think she'll be back soon.
Now, you had completed a release of information. I'm going to go ahead and call her and let her know that this is going on so that she can come home and assist.
Thank you.
Okay, hold on just one moment. Okay, Mr. Barnwell, are you with me?
Yep.
Okay, we're going to stay here together until emergency services arrive. Now, will they have access to your front door? Is it locked or unlocked currently?
It is locked.
Okay. I spoke with your wife, and she said she should be home within minutes. So I believe it will be the case that she will be able to unlock the door and allow emergency services to enter. But let's wait together. We're going to wait until they come. I'm going to stay on the line with you.
Okay. Thank you, Dr. Smucker.
Okay. Once more, you all have met my beloved spouse, who is the star to many a video. I chose this somewhat ambiguous circumstance quite intentionally because I wonder, and feel free to put it in the chat box, tightness in the chest, feeling just a little unreal, problems with energy. What else could that be, if not a cardiovascular event? Could we think of a psychiatric concern? I mean, the thing that came to my mind when we were making it, it would be anxiety or panic attack. Exactly. Thank you to everyone who wrote in. This to me would look also like panic symptoms. And I don't know, to be transparent, I don't know if someone was sitting in my office, would I be magically able to discern? I don't think I would. I think in both circumstances, I would be more inclined to make sure, particularly if someone had a health history, where they had had cardiovascular events that felt similarly, I would be inclined to get them checked out. And this is why, whenever I do a panic protocol with someone, I first ensure that they have been checked out by their primary care doctor, and that we're not treating a cardiovascular event with exposure, because that would be bad. So I think we're always kind of trying to balance that specific client's health history. I tend to err on the side of caution. But again, if this is someone who I know had been checked out by primary care, they were seeing me for panic disorder, they were regularly having panic attacks, I think my response would be quite different. But that's why we leave it ambiguous, is to provoke a little thought and think about what you might do. So let's talk a bit about reporting. And I specifically want to talk about DV and telehealth, domestic violence and telehealth. This to me is part of appropriateness assessment. I usually ask people as part of my intake, do they feel safe in their home? Do they feel, do they have concern of anyone in their life harming them? I want to know about the safety of their environment. any history they might have of perpetration of domestic violence in their life. And I want to be thoughtful about jurisdictional rules. In the state of Washington, as I know in many jurisdictions, it is the case that domestic violence is not a mandated report. And it is tragic and terrible. And I want to be thoughtful about how to get that person the right care. And I want to make sure that they're safe. I've had too many unfortunate stories from colleagues about domestic violence perpetrators either eavesdropping or demanding to be included in a surreptitious way in the client session, and this being a very unsafe circumstance for the client. So because you cannot see anything beyond what your client shows you, I think there is an increased risk for concerns for safety for domestic violence sufferers in their home when receiving telehealth. And I think this is a complex option. I think there are those who say, oh, I don't like to do it, because I feel that the risks are too great, and I appreciate that reasoning. I also think in the context of COVID-19, we know that there has been an increase in domestic violence, or reports of domestic violence anyway. We know people are at risk. I think we know there's impairment to privacy and confidentiality at tremendous risk. And we know people are isolated. They just are not connected to the same social institutions that might offer help or support. And so I think therapy has this incredibly important role to combat isolation and to connect people with the resources they need. But, I think we undertake this with great caution and thoughtfulness. I want to think a little bit about technologies that support us as we manage crises remotely. And again, these aren't necessarily telehealth. I want to be clear. You could use this in-person care too. But, I think that it's nice to know, since you can't hand somebody a flyer as easily, hopefully you can secure message it, hopefully you can fax it, hopefully you can email it, all those things we've talked about in previous classes. But I think it's a nice opportunity to explore some of those technologies that augment care and can, deliver additional support. So this is a giant marketplace. There are so many apps, that claim to support concerns of self-harm or, violence risk assessment or domestic violence. And I think there is incredible variability in the reliability and quality of these apps. So this is no substitute for intervention. And I would encourage you, download a few. They're usually free. Try them in advance, see what you think. But I picked 3 tonight that I think are particularly good. I should mention the telehealth support line, some of my favorites, the National Suicide Prevention Hotline, Crisis Connections, if you are serving veteran clients, the Veterans Crisis Line, and the Trevor Support Center. I think, and thank you to Dr. Simmons for giving us some additional DV support in Washington. Wonderful. Check that out in the chat box. So all of these offer hotlines that can give between session support. Again, it's no proxy for intervention, but it is an additional augment we can offer our clients. I did 3 apps that I really like that I'm sharing with you all. And, I would encourage folks, put in the chat box your favorite apps. If you're using apps successfully, if you're using Crisis Line successfully with your clients, share them with your colleagues. Our community is our greatest resource, and we'd love to learn from you. I like the My3 app, assists in suicide safety planning. I like the Suicide Safety Plan app, which I believe was created in the context of the VA, perhaps from National Center for Telehealth and Technology, I believe. And this runs through the template very much of what you see if you are a VA employee, that gives clients a really nicely comprehensive suicide safety plan. And then the virtual Hope Box, which I think does a nice job of, in a mixed media way, connecting people to protective factors to assist them between sessions. Again, this is no proxy, for the good care you deliver. This is no proxy for those crisis lines, but perhaps altogether we can augment care and give people as much support as possible. Okay, so it's about that time to pause and ask some questions. So David, could I trouble you to help me sort through some of the great questions we have?
Yes, Dr. Smucker, you have quite a range of questions. So I'll start with some of the early ones, and then I'm going to group a couple of them in the middle because they seem to have a kind of a similar theme. But one person in particular pointed out that they use a safe word with their clients in case a certain person enters the room and they need a signal. What are your thoughts about that, and do you have other ideas?
I like that very well. I could imagine it for many different circumstances, but in DV, of course. this is a circumstance where I have met with people in their cars. And, if they are fortunate to have a private vehicle they can meet in, of course, this can signal to the perpetrator that they're going somewhere. I would never have them sit in their driveway and have the session. But if they're going to the grocery store or something like that, we have sometimes done an abbreviated session where they're in the car. They can do that safely. If there is an opportunity, this is actually a circumstance in which I have been a little bit more lenient on the fact that I hate doing sessions outdoors. I hate it for various reasons. I think it's a tremendous potential impediment to privacy and confidentiality. Also, the wind is very noisy and problematic. But me saying I'm taking a walk around the block, and them finding a private place in their neighborhood and having our session there has been a better circumstance than kind of hiding in the house. I've also just tried to be really flexible, with my clients. If they say, hey, I just found out that there's going to be an hour later today, no one else is going to be in the house and we could do it then. I try my best as best I can to flex, and I'm never punitive. I don't penalize folks or, charge them fees or anything like that, of course. But I like the safety word idea. I think it's really good.
Okay. Here's the next one. Then I'm going to, like I said, I'm going to group one. For the client that you were talking about, what if no one was coming home and he was not able to unlock the door for the EMT?
Yes. So that's a great question. I've certainly had it happen. EMTs are really good at opening your door. So they'll get it open. I think they'll break it is often the way. Now, I have heard of circumstances wherein people have a deadbolt or they have a very hard to remove door. It's a tough one. I will say this happens in the case of people calling 911, and paramedics, I believe, have training in how to get into the house. So I've certainly been involved in cases where people get into the house by breaking a window or by breaking down the door, literally. That being said, I will ask the client, is there a spare key somewhere? Could we do that? If they're in an apartment building, we try to call the apartment super to let them in. And of course, if my client, in that circumstance specifically, actually, I would have seen if my client could go unlock the door. That'd be the first stop. Do you feel well enough? Is it safe for you to move and go unlock that door? Yes, there is a risk, that something bad could have happened between, them moving and getting to the door and not. But I think that risk to me would be smaller than the paramedics having to spend an additional half an hour trying to get in the house. So, my first stop would be ask the client to unlock the door. Second would be, is there anyone else who has a key or an institutional key, in a larger community? And third, just trust in the system that they're going to get in that house.
So here's a couple of questions that are kind of together, but I'm going to pose one, then there's another one right behind it. Thoughts about including local police officers in emergency management, given police overuse of violence interventions against people of color?
Yes, this is definitely on my mind. And I don't seek to, I wish I had the right answer, to be really transparent. It's definitely something I'm thinking about, and I think this is where I'm going to research my client's community. I want to know if there's mental health professionals I can call, and that is actually irrespective of themes of race, though it is so much more pronounced in my clients of color. But I want to call those mental health professionals. I want to call someone with the appropriate training. I want to call someone who has a demonstrated track record of de-escalation. And please know I'm not seeking to malign anyone who's a police officer and saying that they could never do these things. But, there's also it is known, that this is people of color are being harmed at greater rates, and that's what's happening. And so I'm thinking about it, and that's why I want to know what the other options are. And so for me, again, the investment up front of knowing, who all we can call, I think helps us bring the right resources to our clients in real time, and in the best of circumstances reserves the police for, more police related activity, so if there are mental health professionals, and the mental health professionals should be helping that client. And I'll be transparent, if I think twice, I think I contact that support person, more, again, if it's so safe for the support person, but I have more reticence and more caution, and maybe, maybe my malpractice insurance would scold me for that, or my risk manager would scold me, but I'm definitely thinking twice.
Thank you, Dr. Smucker. This one's a little bit different, but shed some light on the reduced reimbursement rate if the provider is located at a home office.
Oh, yes. I think this is the issue of the place of service code, and we're going to really dig into this next time. We're going to we're going to pull up screen grabs of CMS 1500 forms and really nerd out with it. So when you complete your insurance reimbursement form, there is a place of service code that you indicate where you're seeing your client from. Historically, it had been 11. You actually, when you did your telehealth sessions, you'd say 11, and 11 means in an office, because I'm sitting in an office. These days, I think in 2018, Center for Medicare Services CMS came out with a new code that said O2, and that indicates a telehealth environment. But one of the really annoying things that happened was that when you billed with that, all of a sudden you got less. And in some cases, most cases where I did it was like $5 less. It wasn't a huge deal, so $5 to $11, but I want my $5, so it was a little frustrating. Here's something interesting, because a lot of these executive orders have required reimbursement parity. They basically said we can no longer penalize people financially for offering telehealth. It's wrong, and it's it's a disservice to the public. And so I think in Washington, they rolled this out saying, well, now you have to pay those 11 place of service codes and those O2 place of service codes the same. What I thought is really interesting is when a lot of the local insurance sent messages to all the providers and said, now bill telehealth as 11. So go back to the old way. And I think the reason is because they can't update their systems quickly enough to make sure that they are paying out correctly. So they've just sort of expected people to know to bill it the old way. It's bananas. So this to me boils down to, a soundbite of just call your insurance provider, call the insurance provider, ask how they want it done. And that's such a pain, particularly if we accept multiple different insurances. But I think it's a worthy call because, in the case of, for example, Premera is a Blue Cross Blue Shield company in Washington that's very popular. And if you were to bill Premera using the O2 code, it's just, you're going to still, despite the legal requirement for parity, you're going to receive less because their systems haven't been updated. So my understanding is you bill it with 11, which is the old school way of doing it, and you'll be paid properly. It's wacky.
So now we know what's coming in the next one a little bit.
Yeah, exactly. Like clear as mud, right? Like, aren't you so glad you asked?
Okay, here's a question from Renee. She's a clinician at a public school, and the time that she's serving the people, the parents are often at work. So here's the two questions. How do you manage risks for supporting children in telehealth, and is consent needed for temporary caregiver?
Can you tell me more? Is consent needed for a temporary caregiver?
Is a consent needed for the temporary caregiver?
To have them be a collateral reporter, do you think? Or
let's see, Renee, maybe she wants to say a little bit more about that.
I mean,
how do you?
I'm sorry, Dave, would you say the first part of the question? I'm so sorry.
Yeah, so here's the first part, the way she asked it. How do you manage risk for supporting children in telehealth?
Okay. I mean, that very much as you do in person. We're getting consent from the child, we're getting consent from the parents. According to your jurisdiction, age of consent may vary. I believe in Washington it is 13, elsewhere it varies. Different states, and different jurisdictions, in case anyone's joining us from outside the US, are going to have different rules around this. So for example, parents technically cannot receive like a session by session update in Washington, but they have a right to all the medical records. So it's like a funny interstitial sort of privacy and confidentiality. We're managing risks, much as we would in person. So in Washington, you are to maintain confidence and maintain privacy from the parents even. And it's really difficult, for folks who see pediatric clients. I will say in my informed consent process, when I see adolescents, I really talk about the types of circumstances in which I'm going to break confidentiality, not just to police, or mandated reports, but to parents. And I'm really explicit with kids about like, these are the types of things I'm going to tell your parents about, and they're the things legally I have to. I think with regard to managing risk in the room, in the treatment room, For the younger kids, I know because we can't be with them, because if I saw younger children, and I could see them in the space with them, and I might have the parent leave for a portion of it, I know a lot of people are just having the parent stay because it's not safe to have like a 3-year-old by themselves. I mean, that's quite young. You would probably be seeing a 3-year-old, but let's say a 6-year-old. So let's say that the kiddo is there. You're probably not going to have the parent just leave them, sitting by themselves for an hour. So many people are having the parents remain for longer, and it makes for a different dynamic. It's a really different session. And then,
yeah, Sarah, Renee clarified a little bit. In particular, like there's a person temporary caring for the child. The release needed for them.
So, I think the parent's going to have to sign it. The parent or legal guardian, I shouldn't be so presumptuous. So, whoever is the legal authority for that child will need to be the one who gives consent. So it's just the same that if someone's aunt or, babysitter or, or temporary appointed caregiver brought a kiddo to my office to be seen, even though it may be absolutely in their best interest to be seen, if they don't have the legal authority to consent for that child to be seen by me, I can't see them. And it's really frustrating. And again, different jurisdictions have different rules. So I'm speaking to Washington's rules. Your jurisdiction may have different rules. But if we wanted to be able to communicate with that caregiver about, any information about the session, then that would be something, again, we would need a release of information from child and from the legally sort of appointed authority, often the parent.
Okay, thank you. One more, or how are we doing on time?
Let's see. Let's do one more.
Okay. This is kind of a little bit more straightforward. What happens if a client refuses to give their information of medical history?
Oh, it's a good question. I mean, that's a clinical issue, I would say. I don't know. I mean, I would want to know why. I'm not saying it would necessarily be a deal breaker for me. And I'm so sorry if there are chair squeaking sounds. I broke my toe earlier today, so I'm like maneuvering myself about. So I think I would regard this as a clinical issue. I would ask them why. It wouldn't necessarily be a deal breaker that I wouldn't see them. I would express my concerns about my ability to provide good care absent a history, and that's part of it. I would, if someone presented as incredibly defended and they were just really closed off, and I thought this was part of the clinical issue, I might be willing to work with them. I actually just had a consultation this week where, and sometimes it just smells funny. I don't know how better to say it other than sometimes, someone's unwillingness to disclose information. I certainly am not in possession of the where or why they are doing that, but I am concerned. And that really goes to where I don't deliver care that I feel is outside my scope of practice. I don't take on cases that I don't feel I'm well equipped to help. And if I really think that the lack of willingness to give me any sort of historical information or my ignorance of that historical information significantly impedes my ability to help, I'm going to be less likely to take that person on as a client or to continue with them as a client, if they won't tell me. But if it's just, if I think that this is the clinical issue and we need to work on building trust and rapport, I'd be willing to invest some time in that. But I have to be honest, I might not be the most patient human being. I don't know. Again, and if they were in emergent circumstances, that's different. If I was worried that they were going to come to harm, imminently, that is different. But if someone's coming into work on their anxiety and they're unwilling to tell me anything, I would be a little, well, okay. But I think that's a personal choice, a clinical choice. I would really want to explore why. I would want to look at this as a clinical issue and wonder if there's this opportunity to build rapport and trust. But at the end of the day, if it smelled funny or if I just felt that I couldn't deliver good care, I'd probably decline to give care.
Well, thank you for all that. I just wanted to note that several of our participants had some really good comments in the chat box too. So I wanted to thank all of them for their comments. So I'll turn it back over to you.
Thank you. Can't wait to read them. Okay, this is somewhat lighter fare. Let's talk about technology disruptions during care. So when the tech fails, when it all goes wrong, this is again something we've talked about in informed consent and where advanced planning serves us very well. And I think there's a good opportunity here to figure out who offers the tech support. If the person's if the product that you're using has technical support, do they offer that in a client-facing way as well as a clinician-facing way? If they offer in a client-facing way, how do we ensure privacy and confidentiality for our clients? If technical support really looks like the client's 12-year-old, are they ready to disclose that they're in therapy? So being thoughtful about who we turn to when there are technical issues. Very often, I'll be honest, I end up being the technical support because most of the problems that my clients have are not really high ticket problems. Most of the problems are solved by restarting a computer, by checking the power source. These aren't really fancy solutions, although I feel very clever when I fix them. But just thinking that through and thinking about your willingness, to be the tech support. And we're not talking about those environmental factors. So again, there are lots of environmental factors that can interrupt our session. So there could be interruptions to your privacy and confidentiality. Our new coworkers in our home office, our children, our partners, our dogs, our cats. There are lots of opportunities to be interrupted. Lighting, can diminish our opportunity to have a good session if we're sitting in the dark. Basically, lots of interfering noise or just inability to see the person well in the camera angle. So all of these things can be quote unquote failures of the technology. But I think we're talking today about things that are a little bit more dire and concrete. So, what happens if the call just drops? I actually had it happen earlier today, and it is so disruptive and terrible. I actually had a session years ago where I was doing prolonged exposure with a client, and we were going through really sensitive information. They were telling their trauma narrative in the context of our session. This was their first time going all the way through it, and the call dropped in the middle, and it was just could not have been the worst time. I actually reconnected the call, and the way it was configured, it picked it right back up, and they were still going, and it was one of those moments of, do I stop? Do I disclose? How do I handle it? So I want to acknowledge that when calls drop, it can be really, really, really disruptive. This is sort of my rubric of the things I'm going to do if a call drops. First thing I'm going to check is the internet. I'm going to make sure that I have internet. I'm probably going to call my client and make sure they have internet. So what I mean by that is I'm going to check for the icon that internet is available, on my computer. And probably I'm going to have bookmarked on my computer a website for doing a speed test. I might have internet, but it might be freakishly slow because something has gone amiss. So I'm going to quickly check that I have internet and that it's functioning at normal speeds. I'm going to try to reestablish through the primary platform. So whatever video conferencing platform I was using, or if I was using the telephone. And if there's something wrong with the platform, if I can tell something's disrupted there, I'm going to have an alternate platform. So this is where, I've recommended in prior classes that we have redundancy, that we have another platform that we can swap to, when needed. If I am continuing to struggle and maybe my internet is moving more slowly or the client's internet is moving more slowly, again, I might have redundancy. So perhaps I can quickly switch over to alternate internet that I am tethering from a hotspot or from my phone. If this is something I'm not as comfortable with, or if it's something that just takes too much time for me, I'm not going to do that. But there are simple things that we can do, such as making the call SD instead of HD. It's going to have less bandwidth on the call, or perhaps moving to a very austere spot that just has less demand. I have to tell you, on bad internet days, I have to hold a pen in my hands because I'm just an unrelenting hands talker. It just puts more drag on the call. And if I can hold still, gosh darn it, it makes the call easier with fewer lags and drops. And I will say, actually, I very rarely have a call drop. One did happen very recently, but it is rare these days. I think technology has gotten good enough. It doesn't happen often. But what does happen to me is I have poor call quality. So what I mean by that is perhaps the visual is pixelated. If I'm doing video conferencing, there might be a disconnect and delay between when mouths are moving and when audio is coming through, or the audio quality might be choppy, poor, or just altogether absent. So in those circumstances, again, I might consider reducing the bandwidth, going SD instead of HD. A very frequent thing I like to do is just mute the video conferencing if I'm on a video call and just have the audio over the telephone. It puts less drag on the call. So all of a sudden the call has fewer requirements for bandwidth and is able to go through more smoothly. And then I can have the audio over telephone, and telephone tends to be pretty darn good for audio. And again, I could change platforms either to an alternative video conferencing product or telephone. What's interesting is when you go to the websites for these video conferencing products, a lot of them will say, if you're having a problem with our product, it's the internet and not our product. And I understand why they say that. There's a lot of wisdom to it, and probably 9 times out of 10, they are correct. And I've absolutely had it happen where a product I'm using is just suffering, and I hop over to another product, and lo and behold, it's working pretty darn well. A product that I really love, and I will not malign them, but they've struggled in the last week or so. And I think it is largely because the type of traffic they are having now is so unprecedented. You know, they never had this many number of appointments coming through. They've had just all these subscriptions, which is great for their business and terrible, you know, for their the strain on their system. So I think, you know, what we're seeing is that some of the products now have just an embarrassment of riches in terms of users. And sometimes the infrastructure is just not holding up as well as we would hope. So sometimes switching over to a different product does seem to yield better outcomes. When the sound is muted, I will also say it's maddening cousin is when beeps are coming through and the sound is not unmuted. That is not an emergency, but when there's no sound. So the first thing we want to do is check on our sound levels on the computer. So we want to check our system volume. So that's something you're going to find in settings on your computer. If you go to that nice little cog usually. We want to check the application level volume. So what I mean by that is maybe my computer's volume is just fine, but you know, I have the sound on my video conferencing program turned all the way down. And I want to think about who can hear who, because sometimes one of us can hear and be heard just fine, whereas the other cannot. Excuse me, no, they wouldn't hear and be heard. That doesn't make sense. One of us can hear just fine and the other cannot. And that will sort of tell us something about whether it is whose computer is having this issue. Because typically, you know, if I can hear someone just fine and I'm not having a problem, but they're having a problem, you know, it indicates to me that the problem is on their end and I can help them solve it, or alternatively, the inverse happens, I can solve it. And again, we might switch to an alternate platform, or this is where if it's a sound issue, switching over to the telephone, I think is very advantageous. So let's see what that might look like. Hi, Mr. Barwell.
Hi, Dr. Smucker.
How are you today?
I'm doing okay. How are you?
Oh, I'm great.
I can't hear you. You're cutting in and out. Okay. Phone. Got it. Yeah, I'll get my phone. Got it. Oh. Hello.
Hi, can you hear me now?
I can. That's much better.
Okay, so here's what we're going to do. We're going to both put our phones on speaker, and we're going to mute this audio, which seems not to be working anyway, on the video conferencing. And that will allow us to have better audio quality in this call. So let's just go ahead and set our phones down close enough to our mouths that we can hear without being disruptive. And we'll just go ahead and have our audio through the phones, but continue to see each other through the video.
Brilliant.
Okay. Okay, so that's what that might look like. This is something I actually do pretty darn regularly. So let's think about Dr. Pink. If you've ever seen the Reservoir Dogs, why do I have to be Dr. Pink? Okay. He is providing therapy to clients for relapse prevention, and the client becomes upset and hangs up on him and says, I don't want to talk to you, Dr. Pink, get out of here. So, you know, this is a circumstance we'd want to be thoughtful about the client's history. If we have any concerns about their safety, I mean, this is a circumstance where I do not believe it would be appropriate, you know, to send emergent services to their home. You know, but that doesn't mean that it's not appropriate to follow up. So I would think about what is the agreed upon plan if we get disconnected. Am I calling back? So I might call back on the telephone. You know, if I was concerned about their level of distress or well-being, you might not reach the level of being emergently concerned, but that might be a circumstance in which I contacted a support person if I felt they were the right person. I wouldn't be contacting their neighbor and saying, you know, Mr. Jones hung up on me, but Dr. Pink might consider contacting, you know, their spouse just to check in if they're okay. You know, and it would be very important about the context. You know, was this a context in which my client was just irritable and not wanting to talk anymore? You know, do I think this is clinical avoidance? Do I think they're just really feeling the stress and strain of quarantine? You know, what do I think are the factors here that are impacting the circumstance? And, you know, kind of think a little bit about that. Let's talk about other tech fails. So not specifically video conferencing or telephone, but let's think about what else. The little things. The number of video calls I've been on where someone just hasn't plugged it in or the plug has fallen out. I will admit to you, this happened on a webinar I did. The computer didn't go off, but I got that bing, 10% left. And I realized some point my power cord had fallen out. And that would have been pretty terrible if my webinar was interrupted because of a power cord failure. Making sure our internet is working and available. And I always check that first thing in the morning because I'd like to know with a little bit of time in advance. So I check my email usually first thing in the morning as I'm getting started because I don't leave it till last minute before I'm seeing clients because I want to know if there's a problem. Thinking about the support person and whether or not, they're actually going to be supportive, including them in the little things. So sometimes I've contacted a support person who sounded great on paper and we had an ROI, and lo and behold, when we contacted them, they were less than supportive. So I think these things can contribute to making the circumstances more difficult and not helpful. When in doubt, restart the computer. So if we're having some sort of, sound issue, some sort of application issue, thinking through who's going to help us and who's going to help the client. So again, do they have someone in their home who can help with technical concerns? Again, this wouldn't necessarily fall into the rubric of 2 emergencies, but could they just help out and, help get that computer restarted and get the person all set up? Document transfers, we've spoken about this at such great length in prior installations of this learning series, but sometimes clients, they just don't listen. So that's okay. Everybody doesn't listen sometimes. But I've had clients go online and find an old CV of mine and find an old email of mine and send an email thusly, with sensitive clinical information. And it's like, oh, hot dog, or somehow find my mobile number, and send that information thusly. We want to think a little bit about how we want to address that. To me, this is kind of a technical fail. This is an informed consent issue, and it's something, as a general matter, I'm not going to respond through the incorrect modality. So I might write them back through the secure message. I might call them, and I want to check in on how they're doing and make sure that there's nothing emergent going on. But I don't want to encourage and behaviorally model the use of an inappropriate method for communication or information transfer. When documentation is just not received. So I've had folks say, oh, I faxed it to you, and there's nothing. Was it sent to another fax? I don't know. Did it ever really get faxed? I don't know. And having some sort of, thoughtful process around what I'm going to do. I'll tell you what I do, and it is incredibly inelegant, but if they have it available, I have them read to me, what they have, what documentation they wanted to send me. And I'm really speaking about assessment measures or homework documents, obviously not a signed consent form, for example. Don't read me my own consent. If it's something that I absolutely have to have the physical copy, I'm just going to have it resent. Real-time reporting, I will sometimes do a screen share of some sort, to share information. If there's something that I want to capture in real time. So let's say there's a measure that they didn't get sent to me, but I really do want to get it in real time, but they don't have it on them anymore. I might do a screen share so they can see the document and respond. I want to acknowledge that when we do it thusly, all norms are out the window, both because I don't think they were normed for remote administration, but additionally because now you're reading them to me and saying them aloud. I have to think that impacts your answers, but there are times in which I think that's okay, and we just do it anyway. If it's not the most sensitive measure in the world, I think it's an okay way to go about it. So again, to me, this all belies the need for an investment in an easy method of document transfer. It's worth our time and money. Thinking about how we're going to receive payments, I do want to acknowledge that typically HIPAA does not require banking and financial institutions to be beholden to the rules. So they really do, they are permissive in our use of payment methods. I will say I personally have a preference for payment methods that are integrated into our electronic medical records. It does reduce a lot of issues, and inclusive of non-payment. So when I have a credit card on file and I have signed authorization to bill to that credit card, whether I'm billing as a private pay practitioner or whether I'm billing co-pays and co-insurance, I think in those circumstances, I just have a lot less non-payment. And so for me, when I've calculated it, the amount I'm paying in fees, which is not trivial, it's usually around 3% annually, well, per charge, I should say, but it comes out to 3% of all my gross profits. will, to me, be less than the amount of non-payment I had previously. So that's a personal decision and something to consider. The only thing I'll say is that I do not like these public-facing payment programs where it tells everyone who paid you and why they paid you and so on and so forth. I feel it's a little intrusive and maybe not great as HIPAA-covered entities. And then finally, and again, we're going to dig into this, much more, I was going to say tomorrow, next week, we're going to talk about the manner in which a lot of these executive orders that have required coverage or required reimbursement parity are about to expire. So, we want to think about what that means. In many places, video and telephone still are not reimbursed at the same rate. In some places they are, but again, these executive orders are expiring. So we want to think a little bit about what that's going to mean for us. And be planful in advance, because I think, let's say I started seeing someone over telehealth and my jurisdiction is opening back up, but neither they nor I are ready to return to in-person care, but the executive order is expiring. So now their insurance isn't going to cover it. So how do I think about, not having a disruption to care? This for me creates a mini emergent circumstance, because I don't want to abandon the client. And I may not legitimately be able to bill their insurance, so how do we think about that? And again, it's going to be on a case-by-case basis, but this would be a circumstance I'd want to think about sooner rather than later, and most often before when it happens. Okay. Dr. Jefferson, should we do some more live Q&A?
Yes, and I don't have any questions yet for this section, but
Okay.
if folks have some,
We can
please.
go right on. In truth, we've only got 15 minutes left, and we've got a few more slides, and then we have one more Q&A. So why don't we move it right along, and then if folks write in with some more questions, we'll get it in that last Q&A.
Sounds perfect.
Okay, great. I talked last time about the Caring Contacts program that is being offered through Northwest ATTC. And I wanted to mention it, one more time, because I think there's this opportunity and it seems very relevant to themes that we have talked about tonight. So this is a program that's being offered through Northwest ATTC, and it is a self-study program that takes us through an evidence-based suicide prevention method for helping our clients in between sessions. So this is a self-paced curriculum, an expected completion time, I think, of about an hour, and it outlines the origins and the empirical basis for this approach to reduce client isolation and potential for self-harm. This focuses in part on the special circumstances and populations for whom care engagement and retention can be challenging, and includes concrete examples of caring contexts, as well as modifiable templates that are downloadable from Northwest ATTC. And so, if any of you have ever heard of the Caring Letters program, this is an analogous thing. This is a circumstance in which we are sending thoughtful and caring messages to clients post hospitalization for self-harm. And there's a strong evidence base that this helps improve outcomes and decrease rehospitalization. So it's a really amazing program, and I encourage everybody to check it out. Yet another way that we can be thinking about investing in clients in between sessions in a way that is remote, and that helps prevent emergencies. I think when we're talking about emergencies, when we're talking about remote management, I think we also have to be talking about coronavirus. And I think we have this initial data that shows us that there's an increase in suicidal ideation in the context of COVID-19. There is an increase in domestic violence. We know this. There's an increase in interpersonal violence, and the impact of COVID-19 on what we know to be risk factors for violence: isolation, diminished treatment availability, diminished engagement in community programs and supports. We know that these things are, simply stated, really bad for people. So I think, being thoughtful about how we can be using telehealth to help offset this increased demand during COVID-19 is incredibly valuable. So, are clients willing to seek emergency care? Can we help get them to safe emergency services? In some counties, I've heard it said that the ER is the safest place to be because nobody's coming in, for little things. And it may be a place where COVID-19 has not had as large of a presentation and they're not overwhelmed. And in fact, it's actually quite safe to send a client in there to be assessed. if they were in Suffolk County a month ago, I might be thinking about that, Suffolk County in New York City, I should say. I might be thinking about whether or not that was a safe thing for them. And again, I want to highlight that, we think about these things much in a way of care as usual. Telehealth is not a clinical specialty. It's a way we bring good care, evidence-based care to our clients. So, I think that, yes, we're delivering care as usual, through telehealth, but there's also this element wherein we are reaching out to people who we know are, in increased stress and have fewer resources, and we're really trying to think about how to get them connected safely and efficiently. So that's a good question. We had some previously submitted questions I thought were really good. I thought was share with other folks. And this one is a video. Over the past few weeks, a few folks have written in and asked me to do an example video that reviews the full informed consent script, if you will, acknowledging that typically, if we were to do this, I would be having a back and forth with a client. However, I elected today not to include a Confederate client in this video for the purpose of really just hitting all those points and those themes you would speak about in an initial informed consent discussion with a client. So without further ado, here is the full informed consent script. Thank you for meeting with me today via Telemental Health. First, I want to pause and confirm that you can hear and see me adequately. Okay. I'd like to confirm that your address remains 123 Skinner Street, and that's where you are right now. I'd like to ensure that you are alone in the room and cannot be overheard, and that any doors or potential impediments to our privacy have been closed and help to maintain our privacy and confidentiality. I want to ensure that your telephone number remains 555-867-5309. Now, if we have any technical problems today, my first step will be to contact you via this telephone number. If indeed we have enduring technical problems that cannot be resolved, we may choose to use a different video conferencing platform, or we could complete our session via telephone. Now, anytime we meet via video conferencing, there is a risk. There's a risk to our privacy and confidentiality that occurs anytime we put information on the internet. Now, I am using a video conferencing product that is designed for healthcare, and there are additional securities and protections on this product that seek to minimize those risks. However, I want to acknowledge that nothing's perfect. There have been some very well-publicized cases of problems with video conferencing, and products designed for healthcare are not, strictly speaking, immune to these. So I want to be sure that we're thoughtful about risks to your privacy and confidentiality as we move forward. The counterbalance to this, of course, are the benefits that we obtain through using video conferencing. I know you and I spoke previously about the benefits related to health in the context of COVID-19. Additionally, we identified some themes around barriers to care in terms of geographical distance you were having to travel in order to access care, child care challenges, and some of the financial implications of that. So I think we decided in our balance of things that the risks were smaller than the benefits, but this will be an ongoing assessment that we continue to examine as we work together. Thank you for completing my online informed consent through the secure portal. Do you have any questions about the document that you completed? In a moment, we're going to go over some of the highlights of that document, including themes of confidentiality, privacy, and reporting mandates for medical healthcare professionals in the state of Washington. However, I want to take a moment to highlight the use of technology that was indicated in that informed consent document. Specifically, as we meet over video conferencing, there may be times in between sessions, that we need to communicate not in real time or asynchronously. And in those moments, we're going to use that same secure portal that you use to upload that informed consent document. So if you need to send me an administrative note between sessions, that's the way we're going to do that. If we need to exchange homework, that's the way we're going to do that. I'm going to ask that you not use email or texting in order to communicate with me. There are secure options that we could use for that if that's incredibly important, but let's cross that bridge when we come to it. If we were to have an issue with emergencies in which you required care imminently for a medical concern, a behavioral health concern, or something else, I want to review some of the themes in that emergency plan that you completed and really make sure that I'm very clear on the roles and expectations of a situation like that. Generally speaking, my goal is going to be to get the right type of help to you as quickly as possible. Most often, this will mean sending medical professionals to your home and contacting the support person who you've identified and completed a release of information for in your intake documentation. Generally speaking, I will remain on the line with you and really try to make sure that you get the care you need in real time. Of course, we can't predict emergencies, so we'll do our best and be flexible, to meet the situation as is needed. In a moment, we're again going to review some of those themes of privacy and confidentiality, but first I want to pause and answer any questions that you might have. Okay. And we'll all do it perfectly, exactly like that every time, right? I don't think I've ever done it exactly like that anytime. But I think these are some of the main themes that we want to hit on, to review those highlights for getting ourselves well situated for a good emergency plan. An additional question I received that was great, and I realize we just have a few minutes left, so I'm going to go quickly. When clients prefer the phone, so folks have said, well, what if my clients don't want video? They don't like it. They're sick of Zoom calls all day. Can we just do the phone? I think it's a great option. I do want to acknowledge that in many jurisdictions, that telephone will be reimbursed at a lower rate. It uses a different billing code than video conferencing does, and insurance companies often reimburse it less. I think that we are a little more challenged to understand, what the distractions might be and we're not doing behavioral observation. So I think when we're doing telephone sessions, really hitting hard on themes of boundaries and really, making sure we're doing everything we can to ask questions, slow it down, and engage the clients, and making sure we're not on Bluetooth in their car with their kids in the back. Caller ID, some folks have said, how do I think about, now that I'm doing phone sessions, caller ID? I could block my number, but a lot of phones don't accept calls from blocked numbers. I do want to acknowledge that if we do tons of phone sessions, if this is really in our practice, many of us may elect to purchase an additional phone line. I know I did for like $10 a month. It wasn't a huge financial burden, but it's still money spent. So another option is to use voice over internet protocol. I promised to do my homework on this in a prior class, and it can be configured to be compliant with HIPAA. And I'm just going to refer you to YouTube because for Skype voice, for Google Voice, all of these products, it can be configured to be HIPAA compliant. It is often, however, not the free version. It's in the context of the version that offers you the BAA. So, whether it's actually cheaper than doing the $10 line phone line, I'm not really sure. But, I'd say check out the YouTube videos. You can do it right. There are some apps also that will help you configure it correctly. Okay. So now we're down to that last Q&A, and Dr. Jefferson, I'll know we're at 3 minutes till, but I will defer to your great wisdom if we should do a question before wrapping up and reviewing those last details.
Well, how about one question, and then I'll do a little wrap up. This one seems quite pertinent to the work that's going on out there in the community. Peter asked, during this period of increased stress, I've noticed increased reports by my clients base of illness and ER visits. Recommendations? So
they're seeing more illness and more ER visits?
That's what I think Peter is saying.
Okay. Yes. I mean, absolutely. I mean, if that's your experience, I think that, it's interesting because I know the ER where we are, that rhymed, in fact, is reporting fewer visits because people are very fearful, but I'm in an area that's been very impacted by COVID-19. So I think people are pretty darn scared to go there. And in fact, even when they really should be going there, I think I would encourage folks to call emergency services and see if there is a telemedicine triage, because I know many emergency services are electing to screen incoming calls when it is appropriate. If someone thinks they're having a heart attack, go to the ER, but if they have hurt their toe, and they're not certain, there is a precedent of many emergency services offering some sort of telemedicine triage to determine whether or not it's time to come in. So that's, I think, something worthy of checking, if it's available in your area. Many insurers actually offer an analog, but, of course, if it's truly emergent, I would never tell someone not to seek emergency care if they felt they needed it. But if I saw a pattern emerging with a specific client, it would be something clinically I'd be really interested in digging into and seeing, what's underlying that. It may just be I met them during a particularly accident-prone and terrible time in their life, or it may be a clinical issue that's worthy of examining.
Well, we had a couple more, and I think what we could do is maybe bring those back to the last session. Does that sound about right?
Yes, that sounds great. So I have the good fortune of getting these chat logs after the seminars, and what I'll do is I will look to these questions to inform next week's That's a Good Question section.
Great, thank you. And I wanted to say next that if you have any other questions of us, actually this email here goes to Dr. Smucker directly. So between now and the next session, it's your last opportunity to ask her any pending questions. And so she'll gather those all up and add them to the next session. So please make use of that email if you would like. And then also would like to request for you all to please fill out the eval. And like I said earlier, you will get certificates for attending tonight. And if you were with a group, please send us the name and email address of the people that you were in the group with. And I also put in the chat box down there that the next session is June 16th, and it's called Risk Management and Telemental Health. So with that, just want to give Dr. Smucker a wonderful thank you, and a big thank you to our audience that, you've hung on for 2 hours. You've gathered an immense amount of very rich information. So thank you all very much for being with us, and thank you very much, Dr. Smucker.
Thank you so much, David, and thank you, Jen, who I know is working hard in the background, and thank you to all of Northwest ATTC, and thanks so much, everyone, for coming. Your time is your most precious resource, and I appreciate your spending it with us tonight.
Super. Good night, folks.
Good night.